Okay, and the purpose of this session is to review and demo contents that currently exist in Cerner and to provide SMEs the opportunity to identify any gaps. Hey, future state end-to-end workflow. Okay. Please keep in mind this is high level, so there are some details that are left out. So for internal referrals, referrals are received within Cerner, and referrals fall under request queue automatically. So when patient calls the clinic to schedule, clerk books the request and creates a print counter.
Then you did.
Oh,
Nothing happened.
someone is not
I fell
muted.
asleep. Well, yeah, it's good. Actually, Angie was very.
Thank you. Okay. And for external or community referrals, faxes land in the work queue monitor. The clerk associates the referral package to the patient and creates a referral encounter and set the status to ready for screening. And we have a question here for Dr. Gee and Dr. Potter. Do the MOA screen referrals at all? Do they do any kind of rejections, or do they just hand the package to you to triage?
So for the external referrals, those are screened, not just by an MOA, but one of our physicians will screen those.
Right. But do they go through the MOA first? Like they have the ability to reject those two? Okay. Okay. Perfect.
Yes. And then the urgency, they need to be screened for urgency.
Yes.
And directionality, whether they're seen in the clinic or whether they're seen in the office.
Okay. All right.
And there needs to be some sort of, so currently the emergency department physician, so this is for the internal referral pathway, the emergency department physician with the current or the previous workflow pathway, they needed to discuss with one of us. They needed to indicate in the referral who they discussed with. They needed to send the referral with a physician's name directed on it, along with information.
Okay.
The internal referral process right now has a drop-down box for who the physician is being referred to. So this is the referral to a clinic not using Cerner currently. And the physician box is not a mandatory fill right now.
Okay.
And so they are meant to still call us, review the patient with us, make sure that it's appropriate for clinic, and then send the referral to a specific physician. That's not always happening. So
because on our receiving side, we're not Cerner, you think, or
I mean, the way that it's baked into Cerner right now is the Cerner referral does not, the physician that you're referring to is not a mandatory fill. It's just the clinic name. And it's actually a referral to the plastics hand and trauma clinic, and it's got a plastics phone number attached to it, which led to a whole other set of issues. But regardless, when we switch to an internal referral, the Cerner referral pathway needs to have a mandatory fill box of the physician that this is being referred to. It cannot just be a direct clinic referral. There needs to be a forced pathway where the emergency physician, because we can't screen these individually if they're accumulated at the clinic side. It needs to be done on a case-by-case basis before the referral gets sent by the emergency physician.
Well, we've already
but they're not.
No, but we,
as long as they call us. But if they don't call us, if they just send the referral, then we haven't screened it. And so in order to confirm that the physicians, the emergency physicians, continue to call us and ensure that the patient is appropriate for the clinic, there needs to be a mandatory fill in the referral system for which physician they are sending.
Okay.
I mean, it'll help that if you down the line, it'll help the task of triage, because then the triage is already done. The person who's receiving this information can already handle it. If there's none, essentially they need to triage it through us, through MOA, through us.
Right, but you're talking about emergency referrals, so that would be internal within Cerner after
So
call.
on the internal side, for the Cerner referral to our clinic, there needs to be a mandatory fill
Yes.
box,
Okay,
which physician they are sending the patient to see, which
Okay.
physician they have discussed the patient with.
sure. Okay, we'll look into that.
For the
Clarifying
external referrals, they do need to come through our MOA,
Yes,
and between the MOA and the physicians, we will screen the referrals.
perfect. Okay, all right.
Can I just ask a quick question about the internal referrals? Would there ever be a situation where an internal referral would come from somewhere other than Emerge?
Yes, they still need to call and discuss with us.
Fantastic. So same mandatory field. Excellent.
In
Thank you.
Edinburgh Field, yeah.
All right, perfect. Okay. So the I'll just continue here. So the MOAs and the physicians, we screen and triage the referrals. So the physicians can either place and accept or rejected referrals within Cerner or continue using current process on paper. So if the process is via paper, the clerk would then update the referral status to accept or reject. The clerk then books the accepted referrals and updates the encounter to a pre-outpatient encounter or the pre-recurring encounter, depending what we're going to use. And the MOA will communicate the rejected referrals back to the referring provider and discharge the rejected encounter. Yes, Dr. Gee or Dr. Potter.
The current pathway is not meant to be that the clerks are waiting for the patient to call them. The current pathway is meant to be that the clerks are meant to communicate the clinic appointment to the patient. The
Okay.
patient,
For external, yes.
so I'm saying for internal,
Yeah.
there is not this wait for the patient to call. It is meant to be. No, we've discussed this, that the clerks were meant to call and book the clinics, but it does not routinely happen. And so we tell the patients to call and book. But when they get a referral through the emergency department, the clerks are meant to book that appointment with the.
So that's not my understanding. So Athena wrote, the issue being that 40 patients an afternoon, not everybody you contact right away, and all this. So what I understood is that they wait for the patient to call, and if the patient hasn't called by a certain amount of time, then they contact.
Okay, that makes sense.
We discussed this at one of the things. This is going to be about a year ago now. There's meant to be a pathway where the patients were called when a referral was generated, but that we continue to coach the patient to call for this reason, that often it's difficult to contact the patient. But I don't think that, I think there needs to be a means for the patient to be notified somehow, either through an email or otherwise, that the clinic has generated an appointment for.
That's going to be there has to be, this needs clarification, I think, through the clerks, because I don't think that's what the understanding of the clerks is. Yeah, and maybe you at that.
Yeah, we have the ability to send automated appointment reminders for a confirmed appointment. The clerks can use that functionality in Cerner once the appointment's confirmed. For pretty much all of our other clinics, it's always been the phone call to confirm the appointment with the patient before confirming it in the system, and then that reminder gets sent in a certain time frame prior to the appointment itself. That's just been the workflow elsewhere that we've seen.
And ideally, it wouldn't be a phone call. It's very time intensive. It's the nature.
Yeah, so I mean, I suppose that's an internal conversation, but I mean, do you saying you're giving them a time to be at the clinic, and then that time is what the clerks book the patient for? Like, are you planning that with the patient when you send the referral over or not?
No, the flow being that the patient, when they leave the emergency room, they have a phone number to call. They call that phone number, and then somebody answers, gives them a date and time to come in based on the referral, because they have a matching referral. So yeah, you were seeing the emergency room, we have your referral, and here's when you come in. And that there was the the backup on that to make sure the follow-up happens is if they're 2 weeks after the referral that they get contacted. Now, Jeff is mentioning something that possibly is different than that. And my understanding is that we weren't going to do the proactive thing because that would mean essentially 200 phone calls. Well, not quite because they're follow-ups, but essentially a large number of phone calls per week and repeat phone calls. That's why we weren't doing that. So maybe there's a different process that you're suggesting, Michael, that's the patients can be contacted directly, but I guess that would be dependent on the emergency room establishing a communication path with the patient. Is that what the other clinics do? Can you walk us through what the other clinics do?
Yeah, for the most part, when the referral comes in from a place like ED, and unless the physician is directing the patient to a certain time and place to be at the clinic at that time, like if I know we're running a clinic next week and I know I have a vacancy at a certain time, I tell the patient that and I communicate that to the clinic, and then everything gets booked and the patient doesn't talk to the clerk at the clinic. That's the other, I suppose, alternative in this scenario, but not what you guys are describing.
And then the other process is that Emerge somehow gets the agreed upon communication matter with the patient, and then when they send the referral, the clinic doesn't actually speak with them, or they like text them or email them, or is that how
if the people if whomever's communicating with the patient in ED knows the time that the clinic appointment will happen, they can communicate that to the patient if they know that they can secure that time without talking to the clinic. And then when the clinic books, there's an automated feature where they can add like a reminder to the appointment that will get sent either via email or by phone via text to the patient, either I think it's 24 or 36. I can't remember the time frame prior to the appointment hours, but there's a reminder that gets sent automated to that email.
But if there's no, but in this case, there might be no designated time, right?
Yeah, so in that case, I think that the clerk needs to connect with the patient to pick a time that's suitable, and then the reminder will still get sent prior to the appointment.
And then how is the connection established between the clerk and the patient in the other clinics? The clerk calls every patient, or did the patient communicate from the emergency room? The patients contact the clinic, or the clerks do that?
We've seen it always be the clerk at the clinic because they have the best knowledge of what the availability at the clinic to support the booking of that patient. That's what we've seen. Okay,
that probably needs to be confirmed because what Tina described was that. Okay, we probably should move forward and just keep that for clarification. Does that make sense? Or
yes, thank you. All right, so this is our understanding. So 1 week prior to clinic visit, providers review the charts and communicate to the clerk. If if referrals needs to be rescheduled, and provider places orders. And 1 day prior to the clinic visit, providers review the chart and place orders for add-on patients. Okay. Clinic visit. So day of clinic visit for registration takes place by flipping the encounter to an active state. The patient goes to X-ray first before being seen by the clinicians. And the clinicians perform assessment, procedure, give any medication, perform any procedures, treatment, and document as required. And follow-up appointments are booked and requisition or prescription given to the patients as needed.
So, yes, it's very hard to reject referrals. So, preparation stage 2, there's not much rejecting of referrals that are coming from the emergency department. Do you ever reject a referral from the new? But I think, but rescheduling is,
right.
That falls more in the rescheduling rather than referral rejection.
Okay. Sure.
What is this 1 day prior to clinic visit reviews and places orders for add-on appointments?
We understand you do have add-ons.
Oh, I see.
Yeah, it may not be one day, maybe like a couple of days
No, no,
prior.
It's the terminology of add-on appointments. We were just wondering.
I see what you mean. You mean patients for that clinic visit, not add on future appointments for a patient.
No,
The
yeah,
patients that came up between the time 1 week ago when we looked at it and then the day prior.
correct.
Yes.
Yeah.
Now, have we resolved this places MI order and other orders?
We have another order set meeting right after, so hopefully we can resolve that.
Okay.
In that session. Okay, all right. Moving on. A review of some action items from last time. So we've updated the clinic description. I listed the clinic provides emergency room follow-up, post-op care, and family physician referrals for patients with simple and complex orthopedic injuries and/or infections to the upper and lower extremities, excluding hand and see clinic information.
Wait
And
a second. We're going to need some clarification on infections of the upper and lower extremities, including hand. We do not manage cellulitis.
No.
We do not manage soft tissue ulcers.
Yeah.
We do not manage and basically soft tissue infections, of isolated soft tissue infections of the upper and lower extremities. So I'm not sure where this and/or infections has come from.
That's me. So I think you're right. We should put and/or bone and joint infection.
Okay.
or joint infections.
And/or bone and joint infections. And then there's another piece. It's not just family physicians. It could be any external referral, like, a cardiologist, or like, it could be, I wouldn't want to narrow that down.
Sure.
So
Any
I don't know
external-
what the best way to say external referral.
Okay. Any
We'll
external
say community.
referrals.
We'll
Okay.
say community physicians, if that's
Yeah,
okay.
it means a physician referrals. Thanks. Yeah. Thank you.
Okay, perfect. Community. Okay, thank you. Okay, and we understand on Friday it's the whole day. And the phone number, we updated that. And fax, I think during our readiness meeting, we've decided to port this fax to the ortho trauma clinic and then create additional queues for the other 3 clinics, the burns and the plastics. That's my understanding. Okay. Next. Okay, and this out of province waiver, it's signed by patient upon arrival to the clinic if patient is not a BC resident, and we do have this available in Cerner. For common referrals for clinics that's already live. Yes.
The governing law, the clerks would have the patients sign that?
Yeah, that's my understanding when the patient arrives to
I
registration.
wasn't aware. These are things that happen in the background that I'm
Oh.
aware of. So that's happening already, I guess.
Mhm.
Does this prompt patients to have to pay up front?
Good question. I'll defer that to.
We
the
don't
clinic.
get, we don't get the patients to pay upfront. We don't have any kind of like payment thing. It always goes to like the cashiers if they need to pay for anything.
But that's what I mean. If they're signing this document, do they also have to go to the cashiers and pay before they're seen?
No.
This is Neil. Yeah, they're supposed to. They're supposed to go and pay first. It doesn't always happen. Sometimes they pay after, but they're supposed to go and to the cashier before they're seen.
Okay.
So, and that's for people who are like Alberta residents?
Anyone out of province that doesn't have BC MSP. Could be international, could be, whatever.
Mhm. So for clinics that's already live, you can place a referral order within Cerner to other clinics. And for referrals to clinics not using CSC Cerner, you can continue with current workflow, whether it's via email or paper.
So right now, clinics that are not on Cerner, we would typically use these whatever red or pink rimmed sheets. Those will still be available in the clinic afterwards, or because I'm trying to see the flow for this.
Yeah, it should be. You would still order from the same
Or
place.
do I have to go to FormFast? I guess is the question, because that's it's a black hole. That's what I'm concerned about.
There's no requirement to use FormFast if you're using the same document in a paper format that's going to get scanned in later. We can make things available on FormFast for printing from there, so that no matter where you are, you can print the same document. But there's no requirement to use it from a how do I get this document printed perspective.
Well, but at one point, then from an organizational point of view, there'll be a decision to no longer having these available. No.
Yeah, I mean, that's not a road or a bridge we've had to cross at this point. And I think because there will always be some clinics that require paper referrals if they're not on campus, you have to have a means to do that. So I don't foresee that going away.
Okay, and then we understand the clinic runs 2 reports. The first one is report 9, which is a slate-like report for a clinician to look at during the day. It includes information such as appointment time, reason for visit, and new or repeat patient. We have the equivalent of this in Cerner or ambulatory organizer. And if you do want to print this out, it's also available in the scheduling appointment book. It's called the schedule report. Oh, in the chat. And the second report is the NCRAP report, which is a billing report. So the Cerner equivalent is the provider compensation billing report. So either the provider or the clerk would print this out. I believe you have to enter a fee code, and then you can give it to the MOA for billing.
You're not required to enter the code electronically.
okay.
It's just, it'll print and you can mark it up as you need to, just like you would now.
Separate to this, could we set up another meeting to walk us through this second report process?
We may be able to demo that today if we can get something set up. I'll take a look in the background.
Thanks so much, Michael.
Thank you. Okay. And if there's any kind of research template or any documentation template, feel free to send it over to us so we can make sure it's available for you. Okay, so per professional practice, so nursing tasks such as casting, splinting, any removal of suture staples, and more advanced wound care treatments will require an order in Cerner. And we're looking into using this OrthoTech service order entry for most of the ortho service tasks. And there's going to be a synonym for this order to make it clear that it's not just for OrthoTech to use. And this will most likely be embedded into a power plan for you to use. And we'll talk about that in the order set session. Any question on this?
I could just see the number of choices that are here to either generate a very long kind of quick list, but it's going to be very long, or a very long entry process during a busy clinic. Right now, it's Neil. I have Mrs. Smith. Can you put a right wrist splint, take a cast off, or take her splint, take her suture, and put a cast. Yeah, or a right wrist splint or something like that. And yeah, I can see the clinic coming to a screeching halt.
it's been described to us that that the detail in this order that's direction for the nursing is something that is a specialized task and that does need direction. That's not to say that, again, the system doesn't restrict the ability of a nurse to transcribe that and send it for co-signature, but as general practice, I think finding ways to support you guys with either quick orders that are pre-filled out with the standard care you'd have done, and maybe within a care plan that has it set for a specific timeline that's normalized for the patient, would ease that burden. But we do agree that there will be some change management required for sure with the new practices in the system.
Already, I'm not doing the factorial here, but the left and right, fiberglass and all these things will quickly expand. I don't think a preset list will be manageable. We probably have a few things. Yeah, we'll need to find a solution, and perhaps a verbal order will be the way to go. But okay, just noting it right now that this is going to be a major showstopper.
I think
I appreciate that.
ultimately there needs to be a way found to offload this responsibility from the physician, because if the physician is doing this, it's going to dramatically affect the length of the clinic. So whether that's somebody that's designated to transcribe these in, or whether it's nurses taking these as a verbal order and transcribing them, and we have to hire 2 or 3 more nurses in order to cover that in the clinic. But ultimately the time limitation or the limiting factor in getting through a clinic is the physician time. And so if for 50 patients we're having to do this, that task in and of itself is insurmountable.
We can only see the number of patients sent to us from the emergency room and the volume from the OR, because there's a process by which the verbal orders flow through, and we have a good collaboration with our nursing team. So yeah, unless we're going to duplicate the number of clinics and number of surgeons, I can't imagine seeing that. Yeah, as Jeff said, I want to stress we have to find a solution.
Yeah, we hear you. We're certainly not here to try and impede on the communication that currently happens between you guys and the nursing. And I think this is probably a conversation that can happen with meeting leadership, or with clinic leadership and yourselves along with us to support. We're just.
Well, I totally understand, but so you also understand that when you say, do you approve this? We're not. So just so it's clear, that process as presented right now is not approved. So just so we're checking boxes, and this is not a checkbox. This still needs resolution.
Okay, thank you.
I have brought up the idea before that for things that we see very commonly, ankle fractures, wrist fractures, clavicle fractures, there is a power plan in place.
Yep.
Where it includes all of the expected items at a 2-week visit, all the expected items at a 6-week visit,
Yes.
all the expected items at a 3-month visit, that can just be checked off when the initial referral shows up. So that might be one way to, in part, offload that responsibility. But I don't think that's going to be the full answer.
Yeah, when we meet with the order sets team after this call, that's when they can tell us what is possible. I have not seen to this date the ability for, based on the diagnosis on referral, an order set to be automatically placed against the patient chart. That's not been something I've seen elsewhere. But again, I think that order set team meeting will be helpful to delineate what we can do in this space.
Thank you. I'll move on to the next one. Okay. So order session is coming right after at 11 o'clock today. All right. So I'll hand over the next portion to Jennifer.
Actually, Tommy, we have Andy available for the registration slides.
Oh, perfect.
Yes,
Hand
hey,
it
I
over
can
to
speak to
Andy.
these. Thanks, Tommy. Thanks, JP. So can you hear me all right? Want to make
Yep.
sure. Okay, awesome. So this slide's just talking about medical service in Cerner. So a little bit of background. It's just something that's used to define the patient's encounter. So it'll kind of show what patient services the patient's receiving at the time of their visit. And it is entered during patient registration. So it can be used to support encounter selection for clerks, and you can help organize or kind of arrange lists using that medical service. So we do have in Cerner the orthopedic trauma medical service, and just want to confirm that that would be appropriate for your clinic.
It's orthopedic trauma and orthopedic fractured hip.
Okay, we have orthopedic trauma, and I believe we have ortho hip. That's the two that are good?
That's correct.
Okay, I will mark that down. Okay, perfect. Thank you. I can go to the next slide now. Okay, so here's just a little slide about our encounter types in Cerner. So I won't go too much. I know there's a lot on this slide, but I'll kind of quickly talk about each encounter type. So the first encounter type there is referral. So that's what's used for your internal referrals when you get a referral into your system where the clerks create to actually put that referral into Cerner. So this is once it's created, it can allow documentation to be associated. And then once that patient is actually accepted to the program or for an appointment, then that referral encounter that was initially created would be then updated or flipped to the pre-outpatient or pre-recurring, depending on what visit type the patient is coming in for. So you'll see that same encounter moves throughout the system and is constantly updated. So next we have the pre-outpatient encounter. So these are for any clients or patients who are scheduled for kind of that single one-time visit. So for example, a single consult or a single follow-up. Again, the pre-outpatient, it allows you to attach any documentation and orders before the patient even arrives, so you can kind of start preparing for that visit. So the pre-recurring is a little bit, it's similar to the pre-outpatient where it's used once you know that the patient's been accepted, you have the appointment ready, and that's when you flip the referral to pre-recurring. But with the pre-recurring, there are some more guidelines around the use of the recurring counter. So the pre-recurring would get flipped to recurring when the patient comes in. And the recurring counter is used for any patients who are receiving a defined cycle or a specific number of treatments in an outpatient clinic. So for example, usually the guideline we go is about one appointment a month to meet that recurring guideline use. I believe for your clinic, it was mentioned that you do treat the fractures and that those patients would come in fairly frequently or perhaps multiple times a week for a few weeks at a time. And for those patients, they would fall under this recurring visit category. Is our understanding correct there? Just want to make sure.
Yeah, there'd be an early follow-up appointment either from the emergency room and from the ward if they've been operated. And at one point we do reach an area where they'll be followed monthly or something. And I'd be interested as well in how committed we are to that. So change of plans, obviously we want to follow the weekly and all this, how that flows through or how that's interpreted. But yeah, generally speaking, that would make sense.
I would say most, at least in my hands, the majority are 2 weeks, 6 weeks, 3 months, 6 months, roughly. Maybe I mean, there's definitely a few week variability in there. And then often by 6 months, they're discharged.
Okay, and sorry,
So
Michael.
I don't know, like, does the recurring have to be like a set, like every Q2 weeks, Q4 weeks, because that's not really the way that it works. And often
Yeah.
it is more than 1 month in between visits. You know, often it could be
Yeah.
8 to 12 weeks.
How do we set the period, I guess? Yeah, or does the period have to be fixed, or what do we have to let you guys know, or it's just to explain to us that there are the different categories?
It's kind of, there is like how do I say it, kind of a best use or best intended use would be for it to have an appointment within 1 month. That being said, we could take this one back and talk further to see if we could get some further approval, but really, so I'll kind of add some more information. That recurring encounter, that one, for those patients that come in fairly frequently or fall under this visit type, they would only have that one recurring encounter to reflect their defined cycle at your clinic. Whereas those outpatient encounters or those pre-outpatient patients, those would be created and booked every time the patient comes in. So anytime they have like a single follow-up or a single consult, they would have a new encounter created. So I don't want to make things too confusing for the clinic as well, having, you know, multiple different encounter strategies. If I would say that if it is like it's very set and defined that these patients are coming in at least 1 time a month, most of the time for their appointments, then there could be value in using that recurring encounter. However, if you know it's kind of sporadic and you have patients coming in maybe quite separate or it's unclear, the outpatient encounter strategy could be valuable as well, or it could be.
So it's not unclear. It has to do with the follow-up and what we expect, the timeline we expect the bone to heal and changes on x-rays. So we could follow the patients every week, but we'd be radiating their arm every week and there'd be no effect to the decision making. So that's why we space them apart at 1 month. Now, the fact that the system has decided that less than 1 month is kind of the way to go, and that's how you decide on recurring. That's you know, CST decision. But from I'm saying that in different specialties there might be different things. And in our field, the once a month, or as Dr. Potters has explained, every 6 weeks would be the typical follow-up. So
okay, I will say that it's not like oh, sorry, Michael, were you gonna?
Yeah, I was just going to say, like, I think what Andy is getting at is that if the clerk is booking appointments to sort of standard outpatient encounters for like a one-off or a patient who's not part of like a healing pathway, then if they're doing that for some, and then for the others that are on, let's say, a pathway of sorts where they come in at 2 weeks, 6 weeks, 3 months, whatever, or 2.5 months, whatever that time frame is, the one that's on that sort of regimented path would benefit from the recurring encounter, and then the one that's not would be the other. And if the clerk is doing both, then they may get confused in the process, but we're hoping to try and make sure that that can be clarified and that both can be used in this space, because we see benefit to the clerk not having to create an encounter for every recurring visit, but also don't want them to be unsure of when to use the regular outpatient encounter. That's all.
yeah, and I'd like Sherry to comment as well, because essentially it's a continuity of the same episode, right? Somebody had an injury and we're just having regular follow-ups. The period of time between the follow-ups is what varies, and it could be 4 weeks or 6 weeks or something, but it's still attached. And appreciate as well that this, I want to limit the amount of work Sherry and team have to use.
Yeah, and I think if those timeframes are fairly set, say it's 2 weeks for the first and then 6 weeks for the second, and then those, if the intervals are set to some degree, that does sort of fit this criteria.
Thank you, Michael. Yeah, that was that's essentially what I was getting at. So thank you for clarifying. But yeah, we can discuss more. I just wanted to kind of give you that encounter type slide just to familiarize yourself with it. We can certainly take that discussion back for CST to discuss further. So I guess I can go to the next slide.
So I'm trying to understand where this fits in. If these are all categories, I could see referral being different. That's kind of your first appointment. But the other ones, outpatient recurring, they're mutually exclusive, or that you choose one or the other? Or?
Yeah. So so back to earlier. So usually when your patient, like the entryway into Cerner, so your patient will come in as a referral. At that point, the clerk would create a referral encounter. So depending on which way the patient's going, so for example, if they're coming in for that single follow-up, that referral would be converted into a pre-outpatient encounter. And at that time, that's when they're scheduled for their appointment to come in. So that would get flipped to pre-outpatient. If the patient's going to be coming in for a recurring series of visits, and they know that when they're booking, then they can create, or they can flip that referral to a pre-recurring encounter. So they are two different encounter types, pre-outpatient and pre-recurring, but they're at kind of the similar stage right now, that pre-stage. Once they come in for their first visits, then either that pre-outpatient or pre-recurring would then get flipped to their respective active encounter, the recurring or the outpatient.
Yeah, I mean, from what I understand, our flow, they would be, the typical one would be referral, pre-recurring, recurring. And then
right.
The period of time between recurring would be 4 to 6 weeks.
Right, okay. So that recurring, yes, that encounter it's one thing. Another thing is that it is not automatically discharged, it is manually discharged. So when the patient's done their defined cycle or that treatment, you would have to put in an order into the system, and then that triggers the clerks to go discharge that encounter.
We could embed an order in a care plan if it were the last visit in the care plan to automatically fire that to the clerk to discharge the encounter. And then if you needed to somehow add on a visit, you could deselect that at the time of choosing. But I think we can find a way around a single order for discharge if it's known that it's their last visit.
So just a little bit of thinking around the care plan or the pathway. So often patients will only have their 6-month visit, for instance, if there's any ongoing concerns, and they basically just don't make or follow up with that 6-month visit if things are back to normal for them. So if they don't follow up, what does that look like? Is Cerner going to bother them that they have to show up for an appointment? Or conversely, if they have issues past the 6 months and they've been automatically discharged, are they going to have trouble getting in to see us if they've been discharged?
To answer your first question, I think so if it's known that they have a request for that 6-month follow-up and that's confirmed as an appointment date and time with the patient, and they get a reminder to say, hey, your appointment is in 1 or 2 days from now, and they decide that they're not going to come, they should call and cancel the appointment with the clerk at the clinic. And so that would be sort of a way to catch those from having to be on the schedule and occupying your time when they're not going to be there. And then to the second point, if a patient has been a patient at the clinic recently and they need to come into the clinic for follow-up, we would see those patients as that sort of standalone outpatient encounter where they've already been accepted. You can see the historical recurring visit that's been discharged, and there's context for care that you guys have already provided ongoing care to the patient. So I think that would be kind of the current state where they call the clinic or call. Do they currently call the clinic to request that appointment?
Yeah, they do, because the schedule is not usually open that far ahead.
Sure. So let's say they call the clinic and they're speaking to a clerk, and the clerk can see that they've had a series of appointments at the clinic recently. If it's standard practice for the clerk to sort of allow, a request to book a new appointment and book one out as an outpatient encounter, as a standalone visit, then that would be acceptable.
Okay. Thanks. I want to go back to the discharge order. So again, current practice is we tell the patient we give them a little sheet. Here's the phone number if you have any issues. I don't communicate with Sherry to let her know the patient is discharged. The clinic with ortho and plastics is 18,000 visits a year, roughly 3 visits per person. So 6,000, that's 6,000 times discharge orders. Wondering if there's a way to simplify them.
So I think Andy's point was that with the recurring encounter at the end of the appointment course, let's say they have 4 or 5 appointments, only at that time would the discharge order be needed to close out the recurring encounter, or some kind of communication to a clerk to say this patient is done with their course of care here at the clinic. It wouldn't be, and it would only apply to the patients that were on a pathway, the ones who were on a recurring pathway.
Yeah, the recurrent pathway is most of our people. It's the rare person we see once and they're sent off. So, so I think we have to think that that's going to be the majority of time. Again, clerical task, not requiring an MD degree to enter into Cerner that the patient is discharged.
So yeah, that's one of the caveats with the recurring encounter is because you do have that open recurring encounter in the system, there needs to be a trigger for the clerical staff to actually get it into the appropriate queue, to get the notification that, hey, this patient's done their treatment in the clinic, this encounter can be discharged. So with those like pre-outpatient encounters, you do have to create an encounter, or outpatient, sorry, if you do have to create an encounter, a separate encounter each time they come in to the clinic. But the nice thing with those ones is that they automatically discharge. So at the outpatient, after they get checked in the next day, that encounter gets automatically discharged. And there's no process involved with the clerks. The providers don't have to enter that order. It is only with that recurring encounter that the providers do need to enter that order to trigger that discharge. So if maybe we can, oh,
You know,
was there another
most
question? Yeah.
So if we do these power plans, the discharge order could theoretically be baked into the power plan at 6 months, right?
Yes, if that's the standard care.
And,
well, it's not. I mean, it's going to be very.
Hang on, but if the patient is discharged, or if that's the baked in plan, but the patient needs to be seen afterwards, you're saying there's still a mechanism that they can call into the clinic and make an appointment afterwards, and the clinic will recognize that this is a continuation of their ongoing care, and they'll book them in for another clinic appointment.
Yeah, they can see that they've finished their routine pathway, so to speak, that they've had all those standard visits, and that the plan was to at that point end the care of the patient, and that now they have to come in again for anything that's unexpected. I think that's something that they can still do. The discharge of the recurring doesn't mean that they're no longer a patient at the clinic. It just means that they're finished that course of care, I think, is the key.
Yeah. Yes. Michael or Tommy, do you think we should move on from this slide for now, just for the sake of time, or?
Yeah, I think that's fair. I think we will, when we talk to order sets about whether or not the discharge order can be embedded there, we'll get the clarification we need.
Okay, sounds good. So this is just another slide. I think we kind of talked a lot about this already, so I'll kind of just quickly skim it. This is just talking about the recurring encounter here, just kind of talking about those guidelines that we mentioned. So we'll go to the next slide.
The only issue is that your rule of no more than 28 days will hold here. So that's what you're going out for.
Yeah, so that's just it's not like a system rule. It's just a guideline that we set kind of as a criteria for vetting clinics that would like to use a recurring encounter. So what I'll do is I'll take this back and we can discuss. There can be some leniency in that. if there is a need for that recurring encounter, there can be some leniency. So I'll take that back and we can discuss that offline. This is just a slide on the recurring encounter discharge, just mentioning again that it is a manually discharged encounter. That end of treatment order needs to be placed for the encounter to pop onto the discharge work list, and for the clerks to get that notification that this encounter can be discharged and that the patient has completed their pathway, that specific treatment course. Okay, next slide. Thank you. This is more for clerical staff, but this is just another thing for recurring encounter maintenance. So there is a work list in PM Office, which is the Cerner registration application. For clerks, there's a work list called the Recurring Reviewed X Days Ago work list. Clerks should be taught, and they will be educated to maintainly monitor this work list for recurring encounters that haven't had any updates on them for the amount of days that they enter. So this kind of helps clerks keep on top of these encounters. And if a patient hasn't come in for like multiple weeks, it'll pop up on here, and it can be a cue for them to reach out and see if the patient's actually still receiving treatment in the clinic. Okay, next slide, please. So this is just quickly, we're going to ask about labels and face sheets in the clinic. So when the patient comes in for their visits, when they get checked in, there's an option to auto print any labels or face sheets at registration. So when they get checked in for that appointment, whatever appointment they're coming in for. Does the clinics do that currently? Do you need any labels to be printed for the patients when they get checked in?
Yes.
Okay, and what labels do you typically use? Do you use armband, or just kind of like a patient form label? These are some of the labels that we have on here. So
We use name labels and the location demographic labels mostly.
and so for the name label, most of these do have our name. I'm kind of like a chart label. Is that what you're referring to for that name label?
Yeah, so the name labels, they usually have the patient's last name and first name, their
Okay.
PHN, and then their MRN.
Okay, so it kind of looks like that patient form label we have there.
Yeah. Yes.
Okay. And you print so when you check in the patient in Cerner, a pop-up will pop up. It's that pop-up on the left there. It'll show you what you want, the default selected. So for example, we could have a patient form label pop up there, but then you also get the option for copies. So as a default number of copies, do you just need one of those when they get checked in, or two? Just one?
Sorry. I can't. Can you explain it one more time?
Yes. So when you get this pop-up, when you check a patient in, it'll
Okay.
have a default number of copies set on there. So I can set that to however many you need. If it's just one that you need during check-in, then we can just set it to one.
Oh, okay. So the face sheet, yeah, one face sheet, but then for the labels, we usually print 12.
12 labels every time
Yeah.
the patient comes in?
Yes. Or when we prep, yeah.
Hi, this is Neil. Cherry, I'm not sure we'll need that many. It will depend on the workflow that we set out. I mean, if we're doing everything mostly in Cerner, the need for that many labels, I think, is pretty small. Perhaps it's something we can figure out as we go.
Yeah, it's very adjustable, I will say. So by all means, you do not need to feel like this is, the final decision. We can adjust this. Even at Go Live, it's very common for people to kind of feel things out and find that, something else works better. So if for now we can maybe set like I don't know, what's a good amount? We could do 4, or we can keep with the 12 just as a kind of initial starting number, and then we can work around that just to see how it feels during the
If we think through here, A lot of the referrals to, like none of the orders would need that. A request for physiotherapy outpatient, I don't know how we're going to do that, but perhaps it doesn't need that. And it might be consults out that are still on paper or other tests we want to do that are still on paper. That's infrequent. So I wouldn't go 12 because I don't think that's we need that many. But we could start with a small number, 2 or 4. Would be my suggestion. Now the thing though that'll be different, Sherry, is that you know how we have these sheets that you print out the progress notes where we write on to those. So we won't need those. We could use the backside of the face sheet. We have to talk through how we want to manage that. Right now, a face sheet is in the manila folder stapled in. The information is there, and then we have separate sheets to take notes around the encounter. I don't have a scribe sitting by me, so it's not getting typed in as I speak. So I need to take notes. So we need to have a process by which we take notes. So if we do this, we print a face sheet every visit. Yeah, that would be one of the solutions, but it's going to need more paper than what we do right now.
Yeah, if you need something to write on, there are some clinics that use the face sheet printed out and kind of use it as like a scratch pad. But I will say that a lot of the information on that face sheet will be in Cerner now. So a lot of clinics do also opt out of that face sheets altogether.
Is there a separate sheet option? Is there like an abbreviated sheet option that is mostly blank that at least has some basic patient information on it?
Not in the system currently. In the system right now, the face sheet, we just have this one. There could be another option potentially somewhere, but at least in terms of registration, what the options are for printing out at that time would be only the face sheet that could kind of fit those needs.
So I'll let Terry define what their needs are going to be, but for us, we're going to need, I'd say, I'd bias with 4 initially labels. Probably the referral demographic label is going to be the most useful for us because we're using it for patient prescriptions and work notes, etc. And we're going to need something that has at least some basic identifiers on it so that we can keep track of who we're taking notes on, that we can write on. So whether that's the patient face sheet or whether it's a simple like blank history sheet that has patient information in the top right or the top left corner, but is otherwise blank, like a historical, like history and physical documentation sheet that we can take notes on, but something that has patient information on it. So if it needs to be the face sheet, then fine. But I think it would be better if it was like an abbreviated sheet that had an external use, like a referral demographics label, for instance, equivalent in the top right, top left corner, but was otherwise blank.
Right. I don't think like in registration or in our kind of label / face sheet library, we have something like that. One alternative, if you have blank sheets of paper, you could have a label print out and then stick that onto that paper, and you have kind of like more space to write, and you have that label on there. But anyways, I will just make sure I have everything right. So for now we'll have one face sheet so that you can see how that works with the printing. And I think I heard it was 4 patient form labels, or was it the referral demographics? And these are just what prints out automatically at registration. You always have the ability to reprint labels at any time. So this is just
referral demographics was the what we, from our point of view, if Sherry has others, just, let us know, Sherry, what would work best for you. But for us, it would be referral demographics label times 4.
Okay, so I'll set it then for 1 face sheet and 4 referral demographics labels.
Now, is that 1 face sheet per visit or per encounter?
per visit. So when they get checked in, this is that pop-up comes up, and then they have the option to print it every time the check-in happens. So yeah, so multiple times you should get that pop-up every time they get checked in.
Sorry, I just also want to mention, Selena, sometimes we would use some labels for billing purposes. So if we need to put them in the air boot or anything like that, so we need like a minimum of 3. But would we have a printer in our station, or Neil, or is it just one by the clerk?
I think it's just going to be one by the clerk. And Michael, I'm not sure if, I can't remember the conversation we have about the billing, if there will be a billing form within Cerner for, things like casts and splints when we're charging patients.
So yeah, just I guess two points. The form that you're hoping to have Dr. Gee and Dr. Potter around making notes for every patient, is that looking like one page for each patient, or could it be a list of patients with some blank space on one side of the form? No.
One page per patient.
Okay, that's a
And the
point of
line-
clarification.
Just basically a blank line sheet of paper. with
Okay,
Demographics.
the
somewhere.
labels. Okay, then a patient form label and a blank form may be the best solution there. If it's going to print for the clerk and they have a stack of blank ones next to them, I don't think we have something formatted to that effect right now. We can double check.
That's fine. If it's a pad of lined paper and
Yeah.
there's a sticker on each one, then that's fine.
Yeah. And then the documentation you do there, you're not hoping to have that scanned into the system, correct? It's just personal notes.
That's correct, unless if medical records says we require that, we'll be dictating from that. So.
Yeah, no, as long as there's a dictated or some kind of a note for the visit, that's certainly within reason. It's not intended to. I just wanted to clarify that point. And then around the splinting charges for splints, I can take that back with our specialty diagnostics team. I don't think we have an order that drops an automatic charge for the.
There's no charge for usually, because you have to go to the cashier, so we don't provide the charge for that. They have to go pay for it.
Correct.
So usually you have I think there's a form you use today. We haven't replaced that. Is it a pink form or something? I think you may have mentioned that. You normally give something, right? And the patient goes over to the cashier and pays for it. Is that correct? Or they get billed afterwards?
They get billed. So I think that, well, Neil, you go through, but it's a 3, I think it's triplicate or duplicate form. A patient gets a yellow, we keep something in the chart, and then something goes to billing. It's got the patient information. The patient signs that they've agreed to be billed about that, and they receive a bill in the mail, I don't know, a month to 6 weeks later.
Yeah. So my understanding that hasn't been replaced in Cerner yet, so it would still be the same form.
Okay, so then we would need 3 labels for that form.
And that would be patient form label we'd need for that, Andy, if you're tallying.
Okay. Yeah, I got it. Thank you.
Why does that have to be patient form label?
I think it's because it has that barcode that you can scan.
Who's scanning it?
Anything that
Good.
has the barcode, it just facilitates when it gets to HIM for scanning purposes. So any document that goes to HIM that's going to be scanned, if it has the barcode, it's just faster for them to scan it in. It's not that they can't, then they just have to manually key in everything in order to scan it. So it just facilitates it.
So HIM is billing, medical records. So is a copy of this going to medical records when we bill somebody for a cast?
It can. We can have it land there and have it be attached to the encounter for reference.
I'm not sure, Michael, I can double check. I don't think that form actually gets scanned in. I don't know how that one works today.
Fair, we can follow up,
yeah.
but if you wanted something scanned, then the barcode is the supporting piece of.
Okay. Okay, thank you very much. So we can probably move to the next one then. Okay, so I think we've gotten our labels for registration. So this is for reprinting for your clinicians. You can have the ability to reprint labels as well. I think for you guys, it sounds like the referral demographics label from earlier would be of value to you to just have that ability to easily reprint it. So we can give you the option. So for example, when you click that, what's called PM print labels, it's a function in Cerner. You have the options to print labels easily for your patient from a clinician perspective. We can set that up so in that same pop-up, you get 4 referral demographics labels. Would that meet your needs? You want some other options as well?
So was it referral demographics? You just go back?
Yep.
Yeah, referral, sorry, yes. Okay.
Okay.
Patient from external use referral demographics. Yeah, for us, I think referral demographics is the most useful for what we're using it for.
Okay. So
that won't necessarily be the case for the other services, but for what we're primarily using it for, I think that would be easiest.
Okay, that sounds good. So we can make sure the clinicians have the ability to print those off. You can print those off anytime. Okay, I think we're ready for, yeah, I'll pass it back to JP. Thank you.
Okay, can you guys hear me okay? So my next few slides here will be regarding design decisions we need for power chart specific configuration for your clinic. So what you see on the left here will be your new order that internal physicians will be filling out to refer to you. It's going to be called referral to outpatient orthopedic trauma. And the location that they'll be able to select will be VGH orthopedic trauma. Given the discussion this morning regarding, you don't see patients with cellulitis, those types of infections. On the right here, there's an example of what we call a reference text. So when this order is placed, well, the question is, do you guys want reference text to pop up to say, this is a clinic that you're referring to, this is a population that's served, inclusion, exclusion criteria. Given our discussion, I'm going to say, yes, we do want this pop-up to display. I will go ahead and work on a shell example, given our information today, to gather what we've discussed, and then we can get the nitty-gritty of the exact details, and then have that ready for you guys at the next session. Does that sound okay?
Yeah, that sounds good. I think the important things are that it specifies in there that each referral has to be discussed with an on-call physician.
Yeah.
Prior to referral being sent, and that the on-call physician that the case was discussed with, or their resident, needs to be specified, and that needs to be a mandatory, where it says requested provider right now. That needs to be a mandatory fill.
So currently it's not mandatory, but I'm going to take that back to the team to see what options we have to either have that filled out.
That needs to be a mandatory fill. That should be a mandatory fill currently.
Understandable.
Because it's not currently, and so if they don't often, we're spending time reviewing the case, making a treatment decision. And then if that referral doesn't go to the patient, to the physician who reviewed the case previously, then they're starting from scratch, and we don't know necessarily what the initial thinking or decision was. So that needs, like, non-negotiably, that needs to be a mandatory fill.
Okay.
They cannot send this referral without specifying which physician they've discussed the case with.
Understandable.
Can you make that like a drop down and have all the physicians' name so that they don't have to type it for all the ortho doctors?
Unfortunately, the way that field works is to type and search.
Okay.
Yeah.
I think one thing just for clarification, I think this field as we see it, is universally found on referral orders for a lot of clinics. And when we just have to clarify how much customization we're allowed to do in this area.
Yep. Thanks, Michael. Next slide, please. So in addition to the order that's placed, we also have the option to create an auto text. A lot of this times is used for when you need specific information from the referring physician to fill out and provide to you guys. So this will be great to put in who you spoke with, where they came in from the ED, what they're being seen for, any attached labs or diagnostics. You can also include problems and medications. So I see this as a yes, so you do need this. It'll be helpful to facilitate that information that you need from, say, from the ED referrals. Does that sound okay? We'll work on an example and send it to you guys.
I mean, no, not really, because we want them to call us at the time that they're making the referral to
Okay.
review the case at that point in time. So all we want to know is that they have discussed this with somebody.
So this is,
Okay.
now, so that would simplify it for them. The only situation I would think that's ED.
The problem is that if the emergency department sends a referral that is not appropriate, there's no means to decline that referral and for that to adequately get communicated with the patient or for an alternative plan to be made. So the decision on declining referral, it needs to be made at the instant that the referral is being made by the emergency physician. There's no stepwise means for a traditional, referral gets sent by the physician at their leisure. The physician then reviews the referral and then communicates whether or not they've accepted that referral, and then that gets communicated back to the patient. Because the patient's gone from the emergency department, then there's no alternative treatment course that's available to them at that point in time.
And the burden of finding the appropriate referral comes on to the person receiving the referral. So
if it's not an appropriate referral, we're stuck with it.
Yeah.
I think, Jennifer, can we go back one slide just really quickly?
Yep.
The sample image you see that has conditions for acceptance to the clinic, this will pop up every time the order is placed. So you guys, as the physicians for the clinic, have oversight of what text appears in this box that will pop up when someone enters that referral. So if the comment is this patient will not be accepted,
but they can ignore that. They can ignore that.
Oh yeah, it's not a hard stop.
And so the reason that we need a requested provider because they will hesitate to put a requested provider in there if they have not actually called somebody and communicated with them.
Fair.
Right? This is a check on them actually going through that process. If they say that they have communicated with somebody and they've put a requested provider in, then odds are they will actually get in touch with us to review that case. If they want to just dump an inappropriate referral, then they're going to ignore the drop down and they're going to leave the requested provider blank and they're just going to send it. That's what I'm saying.
Fair. Yeah. We'll talk to the team for the builds the orders and make sure that we can either look at a field, maybe not the requested provider field, or communicating provider field, something along those lines. But we don't know if how much ability to customize we have here until we confirm.
Yep.
Now, just going back to what was said before, Jennifer, this text that unfortunately I can't see will be provided to us, or you'll be developing something that will go to us.
Yes. Yep. Yeah. After the meeting, I'll go ahead and work up an email and we can go back and forth to see what works best.
I guess worst case scenario, if the requested provider field can absolutely not be made mandatory under any circumstances, then this dropdown needs to specify that referrals sent without the requested provider field filled in, specifying who the case was discussed with, will not be accepted.
You're rejected. Yep. And then I can put ED, we can make it bold, different color, red at the very top. So it's the very first thing that they read on this reference text. So we have a couple options there. And so for the auto text, we'll not go with the auto text for now. We'll stick with the reference text. Next slide, please. So this is the follow-up order that will be created for your clinic. It's called follow-up clinic VGH orthopedic trauma. Based off of the information gathered at the scheduling session, the type of appointment that will be created will be the ortho trauma follow-up appointment. You also have the options for priority, visit modality. You guys do see them in person, and then you have a special instructions field for any information for the clerk. Just wanted to show you guys what that will look like.
So this is mainly for administrative purposes, but important. We do have two services, which are ortho trauma and ortho hip fracture. So if we do want in the background to be tracking that information separately, that would be the difference. The clerk would know just based on what the inpatient service was. Just trying to see how we make that work.
As far as we can tell. Oh, go ahead.
Okay. For if it's if the patient's inpatient and they're following up with your clinic, there is a separate order that will be placed on a slide down below. But this is specifically when the patient is in the clinic themselves and you need to have them follow up. So we can add, I think Mike, you're on the call. We can add another appointment type for hip fracture. So you can get those statistics and get those numbers.
Yes, that's something that could be done.
Can I just clarify? So, in terms of the workflow, if this order was not inputted, for example, would Cherie would have to double check to make sure that there's an order in place before she can book another appointment?
I think
So yes and no. Oh, go ahead.
Oh yeah, go. If the order were placed, it would fall to a queue requesting you to book an appointment with a patient. And if the order weren't placed and nobody communicated to you in person that you needed to book an appointment, then you would have no prompt, I guess is the point.
Okay. So then would there be an option to put these in like a power plan, just because this is like
Yes,
a whole
yeah.
nother add-on order? I think
Yep.
that because the volume of patients that they see, to have to add on like another follow-up order once they're done, I think it's a little bit back and forth, in my opinion, for the physicians.
Yeah, anyone who's in a pathway, we're hoping to embed a follow-up for the subsequent appointment that needs to be booked. Anyone who it's not known what the routine outcome would be, would either need communication to you or an order placed.
Yep. Great question. Next slide, please. So this is what we have in Cerner now. It's called the Continuing Care Follow-up VGH order. This will be used if the instance of the patient is in the inpatient space. So question for the providers, do you see patients in the inpatient space today? And is there when you do need to have them follow up in the clinic, are they simply just seen as a follow-up? Do they need to be triaged again, like a new referral, or they're just already an established patient and they're going to be following up with your clinic?
We do see patients who are inpatients. We do follow them up. Typically, they're not triaged again because the only triage that's done would be, I guess, Sherry, you're looking at who treated them and you're triaging them into back to the appropriate position. Is that right?
Yeah, so any patients who are coming back for their follow-up appointment, we book them back in with the original doctor.
Gotcha. And would that be the inpatient space at VGH? What about the other hospitals? Do you also go to UBC or St. Paul's?
VGH and UBCH.
Okay. All right, so we'll get this order set up for you guys. Next slide, please.
Hang on for this, for us.
Oh, sorry, can you ask that question?
Reason for follow-up. Can you please just remove that as a mandatory field for us? I mean, if they're already an inpatient and they're being seen in follow-up for us, we should have to enter a reason for follow-up because all of our patients are seen in follow-up. And the location should be an auto if we've only got one location.
I think this is where we would set these things into a favorite on your profile. So you could have one for trauma, one for ortho as needed, pre-filled with your standard reason for follow-up and location.
Okay, wait a minute. Like I sense another thing here. So typically the patient is an inpatient
Mhm.
and the CML on the ward is contacting the clinic to get an appointment. So can you explain to me how this flow will be different? Do I now need, when the patient is an inpatient, to organize their continuing care follow-up at VGH?
So this order simply serves to function as a communication that lands on the clinic queue that a patient needs to be booked. So it's just an order that communicates to the clerk a request to book an appointment for the patient. As far as who puts this in, the system will allow both a nurse or you to enter the order on behalf of the patient to have that request sent to the clinic. And so favorites on your profile can be created to do it simply so you don't have to communicate to the CML, or if the CML is doing this with your blessing, then that's a communication through the CML that can be entered on that end.
So I think it should be with the CML. I wonder if there's a plan to discuss with our most common partners at UBCH, CMLs at UBCH and CMLs at VGH about this process, so it's clear what needs to happen, or how different it's going to be from the current state. So
yeah, fair. I think. Sorry, go ahead.
Can we note that and then in our flow of things to do, who needs to be informed about this?
Yeah, we can note that. At this time, I think we're looking to confirm that you do need the order to exist, and that you would benefit from having it flow to this clinic if it were an orderable in the system.
Michael, there's been a number of circumstances where that you've specified that these can be set up as favorites. We're going to lose track of those, and it's not going to happen ahead of go live unless somebody's actually keeping track of them and addressing them. So I don't know if you have some type of running list where each one of these items is going to have to, we're going to have to go through these with the individual physicians and make sure that all these favorites are set up ahead of time. I'm not keeping track of that. So I'm hoping that somebody on your end can keep track of each of these items, where the best way of managing the situation is to set them up as favorites. And then we have a list that we're actually addressing during the build where that's happening.
Yeah, we can track that. We did take a list the last time we spoke around medical imaging orders, and we'll add this to the existing list.
Perfect. Thank you, guys. Okay, if we're okay, we can go to the next slide. So next thing we have here is what we call clinic flag. Clinic flag is basically a flag in the system where you can identify patients that you're following, have been followed, or will be followed. It allows you to track patients if they've been admitted to any of the CST sites, so ED, inpatient. A lot of those times where, I guess there's 2 points here. Do you see a need to be able to track your patients that are admitted to the inpatient or ED space? Do you want a notification that goes into, say, an inbox that states John Smith was admitted to ED yesterday?
Yeah, I think yes, through the ED. I don't think that we need to know each specific inpatient space, but if they're accessing whatever inpatient space through the emergency department, then I think that that's useful for us to know.
So one of the downs.
Is there a period that can be set on that, or not, like a time delineated piece? Let's say it was 30 days post discharge or something like that. Is that, or is it just forever?
It's forever. So one of the downsides is you do have to manage these patients if they're added to the clinic flag list. And then another portion that you did say only, if you want just to only for the ED, the way clinic flag works is it's for all inpatient and ED. So you're going to get inpatient notification as well. If they went in for headaches or stuff, you're going to get that notification as well.
So you understand that the value, and I see value in this for us, is to be notified if a patient has a new visit related to the care or the event where we're involved, but our care is not kind of lifetime in most cases. So my concern is we treat Mr. Smith for their fracture and they come in 2 years, like you said, for a headache, and I'm going to get a notification that's what you mean. So there's no
Right.
way. And it would be for all patients.
Yep. All patients that have the flag.
Yeah, the only thing that would be useful for us, which it sounds like is not possible, is if there was an ED flag alert for 30 days post initial point of care. But if that's not possible, then
As of today, that doesn't exist. I can take it back to see what we have as options and bring it back at our validation session. But
I
as
think
of right
you
now,
would find that if you'd probably find that if you presented that to the surgical specialties in general, like all surgical specialties, 30-day post surgery, return to emerge and all this is something that has value, that's recognized in the field as being associated with the surgical encounter. So that's why we bring it up. It's nothing special. That's from us. You'll find that this 30-day piece would be a key.
30-day post. Okay. I'm taking note of that.
Thanks, Jennifer. The rule that we're looking at building here is attached to the outpatient location. So because this patient is a patient at your location, and you've added the flag to their profile, then the admission prompts the rule to fire to you. If other surgical specialties don't have clinics on Cerner, then they're not eligible for the process, just as a general rule. And yeah, we'll take back whether or not we can customize it to look at a time frame or a ED only purpose.
But the ones that are on Cerner could benefit from this.
Like anyone's in VGH.
Yeah. Agreed. Yeah.
Yep.
Yeah.
That are on Cerner would potentially.
Yeah. And then you can think from a quality improvement point of view, if there's possible to generate a report from that, would be very helpful. If you need additional arguments to make for this, so just no,
We will definitely reach out.
It's the standard of care since I think 1830s or so in Mass General Hospital in Boston. So the 30-day post event. So yeah.
Gotcha. Okay. Next slide, please. Yeah, we can skip this one. The next decision or discussion is regarding the options for requisitions. So in Cerner, we have, I would say, 3 options for requisitions. When you say place an X-ray order, a lab, or any diagnostics, we have a tool called Requisition Manager, and you'll see in the screenshot here that it's a one-stop shop for all your requisitions at the clinic. And my question for you is, let's see, automatically when you place that order, the requisition will print at the nearest printer to you. Some clinics don't like that because 1, you have to go to the printer, or 2, the patient might not be there. 3, you have different people printing out requisitions. So an option to use Requisition Manager would to have this tool available so you can, 1, see at a glance all of the orders that were placed, and then you can action them and print them from here, and also be able to track them if it was printed or not printed. And then you can also see the different statuses if they were booked or not, and then add a comment. So this is the tool. The next slide, please, is what we call IP-PDF. It's basically integrated printing. What you'll be able to do is everybody gets this. You'll be able to go into what we call IP-PDF and print individual requisitions as needed. So this doesn't go away. So next slide, please. So here's the decision maker that we need from you guys. We have the option, you can go with Requisition Manager, which was that first slide with a one-stop shop. It's our preferred option for multiple staff clinic where you have either one person or multiple people responsible for providing the requisitions. We're also able to keep track of the requisitions, set different filters. And one of the cons is if we go that route, it does have to be managed, where the automatic printing of the requisition will no longer occur. They all go to what we call requisition manager.
Give me an example of what type of requisition you're talking about.
Let's say an X-ray, if they need to come back for an X-ray at
So-
the 4-week mark.
So we need to put in the X-ray order in Cerner. And
Yep.
then we need to pull up the requisition manager and again input it in the requisition manager.
Nope. So that order will automatically, once you sign it, go to requisition manager, and then the clerk or whoever else, nursing, clinical staff, have that option to go ahead and then print it. So for you guys, as long as the order is placed, it'll then flow over to requisition manager.
And every time, every pending X-ray that we have on a patient will show in our requisition manager.
Correct.
That's going to be 1 million X-rays for each of us. Right?
So-
Because each individual patient is going to have their 2-week, 6-week, 3-month, 6-month X-ray in this requisition manager.
Yep. So the requisition manager isn't often actually used by physicians. It's mostly used by clerks. So this also spools any requisition that automatically spits out of Cerner. So this also includes labs. So think about our chemo patients. What happens for those patients is, a series of labs will get ordered, the 14 requisitions will spit out for their, next 12 weeks of care. And then the patient will leave the physician in the room, walk to the clerk, and then the clerk will print them out for them and hand them over. So it is an option. That way the clerk can batch what they're printing as opposed to just having them automatically spit out of the printer and then having, if you're managing, 5 doctors at once, the recs can actually get misaligned instead of collating them. So this does help with the clerical workflows.
So then the next question is for our clinic, what requisitions are actually going to have to get printed out? Because X-rays are going to go automatically into Cerner. They shouldn't have to be physically printed out, right? Labs.
We do print them to make sure that patients have a physical thing which serves as a reminder to them.
They're walking across the hall. Like so we're printing it out and they're walking it to the desk across the waiting room and giving it to the clerk there.
We'll already have, but presumably the clerk will already have that on their screen.
Yeah, in that case, it might not be necessary to print them. If we make an agreement with the medical imaging department, normally we give them out, if the patient's going to go wherever to get their X-ray done at a different time, it serves that purpose for them. But in this case, it might not be necessary.
That's probably not necessary. So now the next thing is like a CT scan or an MRI. Currently, we don't give the patient a copy of that. It goes directly to medical imaging, and medical imaging then contacts the patient to make their appointment. Same with ultrasound. So is that workflow going to change?
Yeah, it's Karen from Medical Imaging. Can you hear me?
Yeah.
Thanks, Karen. Yep.
Yes. Hi. Yeah. So no, that patient does not need a requisition for ultrasound, MRI, or
Okay, so they
just X-ray. We prefer the patients to come with the paper requisition. It would help the clerks to identify, this patient has this order, so they know what to activate. But for other tests, the requisition is not needed.
No, I can't find any extra orders.
Okay, and then
Why do you?
so I don't think I'm getting the sense that I don't think that we're going to make great use of the requisition manager. I think if we need patients to go for a lab, I'm not going to pull up the blank lab form and try and do trying to do it in Cerner. I think we've decided that for MRI and for lab requisitions, we're just going to fill them out by hand. So yeah.
So we might have to take that decision offline. So the standard is that if the patient is going to go to a Cerner lab. The labs should be in Cerner because the lab actually has a much easier time activating them and ensuring that they get the correct orders if they're done in Cerner.
This is for if people are going to walk into a Life Labs off of Broadway.
Yep.
Is that good, Cerner?
Also for, no, it's not, but they accept our requisitions. So it does ensure that they have the necessary information because we've configured and gotten agreement across the province that anywhere will accept our requisition.
Okay, so right now, patient needs a blood test. You don't worry about infection. I take the tear off pad, I put a label on, and I check the boxes, hand it to the patient, and they go out and get their lab test done. 10-second event. And so now I go into requisition manager, have to enter that either.
No, sorry. Yep. So the requisition manager, you don't actually input anything in there. So you do all of your work in the orders profile, and then instead of spitting out a piece of paper to a printer, it actually just shows up as a PDF in both IPPDF and requisition manager. So you would use your quick orders in that case, and we'll show that in the demo. And that will be, you know, CBC, you know, clotting factors, INR, whatever, 2 clicks, and then click sign, and then it will automatically spool out a piece of paper, and it will show in requisition manager or automatically print out.
But it's
So it's
not,
4 clicks.
It's not that. It's opening Cerner. It's logging into the computer, opening Cerner, finding the patient, pulling up the patient encounter, and then finding the order that you want, then filling out the order, and only then you're getting to the 3 clicks point, and then it goes to the desk. So already you're at like at minimum 2 or 3 minutes at minimum versus a 10-second event. So with all due respect, unless there is absolutely no mechanism by which we can continue doing the current 10-second protocol, then that's what we're going to continue doing because we don't have the capacity to do it any other way.
If you're already in the patient's chart, it is pretty much 4 clicks.
We are not already in the patient's chart.
Okay.
We're running from one patient to the other to try and get through 50 patients in an afternoon. So we will not be opening each individual patient's chart unless we absolutely have to as we go. This is not a leisurely sit down, half an hour per patient, pull up their chart, review all of their last labs. We're not going to be looking at x-rays in Cerner because that, in order to look at x-rays in Cerner, we have to pull up each individual patient, which we won't have time to do. We're going to be doing it the same way that we currently do in PACS. So, so keep all that stuff in mind that it's not quite that straightforward. So, and the same for CT scan, the same for MRI. All of those things take us 10 seconds to do right now with a pre-printed form. So unless those avenues are closed to us, then we'll probably continue doing that because there's an extreme loss of efficiency otherwise.
Our other option is we're going from 50 patients in an afternoon to 20, which is not going to work with the emergency room inflow. So that's our concern. So it's not that we're trying to resist change. It's nothing like that. It's really more that we have this huge swell of patients that put through, and we put a tremendous amount of patients through, and all these steps that are described essentially add on to that one encounter. So,
yep. So we are trying to find ways to make it more efficient for both you and the clerical and nursing staff, not just both, all 3, you know what I mean? So requisition manager is one thing that makes it easier for clerks. So if the clerks feel that that is a better workflow for them for the orders that you do put in Cerner, then it's an option.
And I also want to add, at Go Live, we've had clinics that don't have requisition manager turned on and find out, say, a week later, like, oh, we actually do want to test it out and try it with the clerks to help with their workload. We have that option as well.
That's a really good point. It can be turned on or off.
Yeah.
So
Yeah.
I'll ultimately leave the decision up to the clerks because they're the ones that are going to be front facing on this. I think the decision point that's going to be important for them to decide whether or not they want this. The biggest workload will be if the patients who are checking in and then have to walk across the hallway in order to get their x-rays, if they need a physically printed out copy of their requisition, which I think is a huge waste of resources and totally is counter to the whole reason of doing this extreme change over to paperless. Anyways, be that as it may, if they are going to be forced to print out a paper copy of that requisition to take across the hallway to the clerk at x-ray, then they're probably going to want this so that they can access that easier.
The other option, I think I'd like Karen's opinion here, is if we're not going to make the patient take a requisition across the hall to medical imaging, then requisition manager might actually be the better choice for them, because then it won't spit out of the printer automatically. So we're saving paper, and then the patient can just go across, and then the clerk can just clean them up at the end of the day and just, mark them as not needed to be printed. Because I don't think we can turn off the requisition printing altogether.
Yeah, I will discuss that with the clerks and the clerical leadership if that is an option. And we understand that orthopedic trauma clinic is super busy.
Yep.
So yeah, I will discuss it with them and see, let you guys know what they say.
Okay, so we'll take that one as a follow-up.
Yes.
Yeah. Okay.
Sounds good. Thank you. Okay, next slide, please. Now this one here is, once a patient is checked in for the day, you'll see that the patient is checked in under the status column on the far right there. I understand that you do have 12 bays to help facilitate where the patient is located within their visit. Do you guys feel the benefit to create what we call rooms on this schedule? So do you want to see if the patient, is in bay 5, or will that still better be continued on paper on the chart?
Can you explain how this works? So
Yep.
at any given time, there's 1 or 2 or 4 physicians seeing patients, and what the process would be for these 4 physicians to know that somebody's taking care of this patient. So is there a way to check that says, Dr. Potter's got this? How does this work?
Yep. So when the patient's checked in, you'll see on the first column that where it says Andrea Simmons, that'll be which provider is seeing that patient. And once they're checked in, the color here is blue. So you'll have different colors of patients that are checked in versus confirmed. And then from there, let's say if they go to X-ray and they're not physically in the clinic, you have the option, this is usually done by the clerks or the clinical staff, to open up this drop down that you'll see here as an example for BCH ortho trauma. They actually use patients either in waiting room, which is WR. They can select XR for if they're at X-ray, or if they're any of the exam rooms. And anyone has access to go ahead and change these what we call statuses or rooms to indicate where the patient's at. And that's pretty much how the easiest way to see who is seeing the patients and where they are within the clinic. Otherwise, it's just going to say checked in, and you're going to be questioning, have they had their X-ray? Are they checked out? Are they still in room 4? We can build the rooms. A lot of clinics build the rooms, and you test it out at Go Live to see, oh, actually this is really beneficial. Or if not, then you don't need to select one of the rooms in the drop down there.
So how does
to Andrea Simmons, the physician, how does that get assigned to Andrea Simmons?
That's actually all part of the scheduling. So if it's a follow-up, so this one here is actually an ortho trauma follow-up, you would have already placed a follow-up order that flows over to the clerk onto their scheduling applications, and they'll go ahead and book them. And once the patient's already booked and they're checked in, this is a screen that you'll see within PowerChart called Ambulatory Organizer. And so this is all flowing from the scheduling book itself. So you'll set up your filters to see, say if you only wanted to see your clinic, your patients for that day, you'll set up your filters to just your name. Or if you wanted to follow multiple providers or a group, if you want to follow everybody, then you can set up that filter as well. So it just depends on how you set up the filters, and then you'll see the schedule for that day. We can show that in the demo as well.
I think that probably this is not going forward. That the way that it works for the person is that they bring a patient into clinic and into the physical clinic space. And they basically slot them into whichever room is available. And then on that same face sheet that we've discussed, that we'll have to have either the face sheet or that line sheet of paper that is on a physical clipboard, they can indicate the room number and one of the physicians will pick it up. I think that's that workflow is going to be, rather than I don't think that we're going to follow the location on this ambulatory organizer, because I think the turnover is too quickly to adequately keep track of that.
Understandable.
Neil, what do you think? And Selena, on your side, is that something the value having, like assigning a bed or something? I thought this was, you know, instead of Andrea Simmons, it's you know, Resident Smith who picks up the chart, and that tells me that Resident Smith's seeing the patient. But this will be just the assigned MRP for that clinic for that day. It's all like if we were to see the whole clinic for that day, we would see all Andrea Simmons. It wouldn't be necessarily the physician who took is actually assessing the patient. But Neil, is it value for you?
You know, in a way, it can be, just because they're check-in, we don't actually know if they're actually been placed in a room. Say if there's like 4 other nurses and there's more patients, and it would be a nice overview to know that, okay, they're checked in, but they could also still be in the waiting room unless the color of this banner changes when they're brought in. But I do understand that, yes, like, because I also work in the other clinic, and sometimes it's hard to keep up with changing the location of the patient. But because, yeah, it's hard to say, but it would be nice to have that, just so that we're not like asking people like, oh, was this patient brought in yet?
Yeah. Does that do you see some functionality in pulling the patients out of the waiting room into a bed? So you know now how once the patient's gone to X-ray, we have like this manila folder chart that gets put in sequence, and then you just take the first one, meaning the patient's been presumably is next to come in from the waiting room, and then you assign them. I'm just trying to understand how this would work potentially for you to, you know, identify who this next person has been added to kind of create that functionality. Like, well, yes, assigning a bed is, understand how that works, but the other part is, you know, actually bringing somebody in from the waiting room.
So it sounds like, in terms of our workflow, would we still have the face sheet? Is that something that would be put in sequence again?
Absolutely.
Sorry, I missed that.
Every patient is still going to have a face sheet on a clipboard with minimum four demographic stickers attached to it. And that's going to be placed in sequence the exact same way that it currently is. It's the only way of managing this. Is there a way, can I ask? So my concern with this is that, you know, somebody might come in for 30 seconds. We see that they've got a cast on. They come out of the room. They're going into the cast room to get their cast off. They're no longer occupying that space. But we haven't had time to update this system to show that they're no longer occupying exam room 12 And now somebody else cannot be put in exam room 12 because we haven't cleared out whoever was previously in exam room 12. So that's my big reservation for this, is that it's going to affect patient flow, because we're not going to be able to keep up with the rate of change of patients in each space, in which case we're not going to be able to allocate patients to a space because the last patient hasn't been updated to be out of there. But I understand the benefit of tracking where the patient is. So rather than having specified exam rooms, can we have waiting room, x-ray, clinic, indicating that they've been brought into the clinic space without assigning a specific room?
I think that's actually a good idea, just because to keep track of all the exam rooms and constantly changing it would not be ideal with the
Yep.
workflow.
Yeah,
So
we
if we
can
could, I guess,
definitely.
yeah, if we could simplify it, whether or not we use it, great, but I think it's not gonna prevent the patients to be seen. Like, it's not something that has to be filled out.
Correct. Yeah, so I can go ahead and configure the 3 spaces, waiting room, x-ray, and clinic space, and we can test it out at validation and see how that looks. And then it's if you guys would like it, we can go forward. If not, then that's okay. You'll still have the manila folder with the paper and follow that route, given the number of clinics that you guys, number of patients you see in a day.
Yep. Jen, can you confirm also that like it doesn't work like bed assignment in Cerner? Like if somebody was in 14 and then you click that the new patient is in 14, it will let you do that without having to go back to that other patient?
That's right. Yeah,
Okay.
it doesn't.
Okay,
it
so it
doesn't
overwrites
block
for you. Okay, that's good.
The other thing, if the nurse does document on the power form, we can change the color so that it from the, like when you've casted them, for example, we have that power form, we can change the color to update like a rule so that you can see that you're done with them too. I don't know if that'll help as well.
I can make note of that, and then we can demo it at the validation session, because we do have different colors. So once it's seen by nurse, I believe it's orange. I can't remember off the top of my head. And then once you're seen by a provider and you've say placed an order or wrote a note, it'll say seen by provider. So that'll kind of help you with the statuses of if they were seen, where they were seen, who saw them, and if documentation was completed. All right, thanks guys. We'll go ahead and go with the 3 rooms and then go from there. So the next decision is what we call message center pools. Part of our standard build is to have 3 different pools. One, are you familiar with message center, Dr. Gee and Dr. Potter?
Nope. Oh, message center, yeah. Yeah.
But not the pool.
Okay. So you'll see on your message center that there's a pool tab. And basically it's simply as that. It's a pool where you can send messages to that specific pool, and anyone opted into that pool will get that message and be able to respond to it. A lot of the times it's beneficial. I've seen it used for, say you have a patient that calls in between their patient visits and they have a question regarding their care. The clerks can then send a message to a pool, or you can send the message directly to a provider. Currently today, do you have messaging capability to say either a group of folks, or is it all individual communication, one-on-one, face-to-face?
We have customized communication from Sherry, who writes up a nice note about our patient and lets us know we need to take care of things. So, and that's dropped on our desk. So for next time we're there.
Okay. So with that, Sherry.
But with this format, I mean, I check my messages on a basically daily basis. So if Sherry was to send me a direct message in messages, then that would be fine. But
until the minute
to the pool. But like not to the pool of the surgeon. Like if it's my patient, I want her to send a message to me.
Right.
I can't think of many circumstances where I would want messages regarding my patient's care going into the pool of trauma surgeons?
The most frequent use case for something like this is where there is a person of the day and that rotates, and someone needs to be watching that pool on that specific day for something that might come in. If that doesn't apply to you, then the direct message may be the best way to proceed.
And with this, within this message system, that this is always dependent on when the physician looks at the message center, there's no prioritization or other kind of message. There's no faster way for Sherry to get a hold of us.
I mean, it requires you to look at it just like an email inbox. The added benefits of Message Center is that they can message you from in context from within the patient chart. So from directly within the message, you can access the chart that's being referenced, and they can, and so that's an added benefit.
Okay.
Okay. Thank you. Next slide, please. So the last decision I want to discuss with you guys is what we call clinic inbox. Not the best solution for all the clinics. So do you have clinician of the day or provider of the day?
Nope.
Type of
But we have
workflows?
on-call person, but talk to us about this.
Do you share results, responsibilities? No.
No.
What about nursing? Does nursing share responsibility of reviewing results?
No.
No. Okay. So if any of these were yes, we would have gone ahead and go to the next slide regarding what best works.
Can you clarify for me the process for forwarding messages when somebody is away, like forwarding results and reports when somebody is away? Because I'm trying to see. You have to understand that in this process of a meeting, you're explaining quite a few new things to us, and you're requiring within 30 seconds or a minute for us to make a decision on that. And then we need to contextualize, try to see how that fits in. And so sorry if lots of interruptions and questions, but it is essentially what you're asking us to check off on. So can you clarify a little bit more about this clinic inbox and how that works?
Yeah.
Not the clinic inbox. You on the last slide. I think one of the things that we're wondering is if somebody's away, the same way that you would for your email inbox. If somebody's away, is there a way to have an out of office notification so that if we are getting a message directly about one of our patients, but we're away for a period of time, that Cherry or whoever's sending that message gets a notification that we are not available to respond to that concern for a period of time, which would then prompt her to reach out to somebody else.
Yes, there is an option to set your inbox as out of office. And what you can also do is set what we call a proxy. So you can send you have someone else that's covering for you or the on-call doctor to proxy into that inbox. So that way your messages aren't missed or results or any type of documentation. You can set it up to say you can have a proxy covering just your lab, your imaging, or your whole entire inbox. So we do have different option settings for that instance when there's no one there to cover or when you're not in office.
Can we proxy to a pool?
We cannot proxy into a pool. So, but everyone has an option to opt into the pool. So there's no need to proxy into it. You'll just add yourself to the pool and then all messages that are sent there, you can see them.
But like, for instance, if I was away, if I was here, I would want messages to come directly to me. But if I was away and I was going to set a proxy, could I set the proxy while I'm away for those messages rather than going to an individual? Could I set them to then go into the pool that the other trauma surgeons would each see them? You know what I mean?
No, yeah. One of the functionality, we can't proxy into a pool because it doesn't function as, say, a physician, where you're going to be able to action off results and documents or labs. So the best way is actually to proxy individual proxies into say if you're gone, then all the providers will proxy into your inbox specifically instead of into a pool.
Okay, thank you.
And then I can explain a little more on the clinic inbox. So what this is, if you go to the next slide, Tommy, a lot of this is best used for clinics that have clinician of the day or shared responsibility of results. What it does is when this example here is when a CBC is ordered, the system will automatically put in what we call a clinic inbox mailbox attached to that order. And when the results come in, it goes into that pool or that inbox for whoever of the day is looking at results. Usually it's good for urgent care and multiple clinics that have multiple providers looking at all of the results. But since you guys are individually, you're responsible for your, orders and documents and notes, and they're not shared, I don't think clinic inbox would actually be beneficial because it's actually another inbox to look at versus having to just review the original results within your own box.
Yeah, I think for that, this won't help, but the proxy will be more helpful with setting the proxy.
Yeah, and we can definitely help you guys set up proxies at closer to go live. Okay, and I think that's all I had, Tommy. Yep.
Just wanting to take note of the time. I realize that we've taken quite a lot of time to get to this place. How are you guys, Dr. Gee and Dr. Potter, this morning for time?
I've got a patient waiting for me across the hallway here.
Okay.
That I should see before our next order sets meeting.
Okay.
Pierre probably has to take care of some things before the next meeting.
Should we regroup and try and set any additional time with you two as needed, and we can try and focus on some clerical work? Neil, I don't know if your group is capable of staying a bit longer to see the clerical pieces.
Yeah, I think it's fine.
Do you
Jerry, how are you doing for time?
Cherry set up quite a busy clinic today?
My clinic begins at 12 o'clock.
Okay. Just I know we're a little short on staff today.
Mm-hmm.
Okay.
So I think we're good to go for just a little bit.
Okay. So to that end, I think Dr. Gee, Dr. Potter, we will.
Okay, thanks. See you soon.
We'll reach out to you, and let you come back with another time to see more of a demonstration on that front. Okay, Tommy. Oh, if you're speaking, we can't hear you. It might be me or it might be. I can see your mouth. Is it just me? Can everybody else hear Tommy? No, it might be double mute. No problem, Tommy. You just need to look at your audio settings for. Oh, no, unfortunately, it's still not working for us. It might be in the Zoom audio settings down by the microphone icon on the bottom. Sometimes it's.
Okay, is it working?
Yeah, you're good now.
Okay. Happened to me last time too. Okay. All right. I'll go over the clerical, the nursing, and PT demo if that's okay. Okay, just 1 second. Okay. So for the first piece is for the clerk. So external referral will land on the VGH, or it should be called ortho trauma queue. And then what you need to do is to associate this referral order to the patients. So you can do that by double clicking. Okay, so we're going to find our patient. So I'm just going to use this patient. And then I want to create a new referral order encounter. So I add encounter over here. I'm just going to use VGH trauma for the demo purposes. So you're looking for your patient in the external master patient index. And for some reason, we have to do this twice. Okay, update the demographic. All right. So a couple mandatory fields we have to complete. The first one is the encounter information. So it's a referral encounter and the medical service is trauma for now. We're just gonna say referral for reason for visit, and then you want to enter the referring provider as well. And the next piece is the referral info tab. So the referral receipt date, you can say today, and the referral status, we're gonna set it to ready for screening so the MOA can screen for our patients. And then I'll go ahead and click complete. And then we do not want to print anything. So we'll just go okay. All right. And then you want to set the status to complete and click OK. And then this should fall off your queue. Okay. So now the MOA is proceeding with screening the patients. So they would go to PM office. They would go to the referral management conversation. And they would find the patient. Locate the correct encounter type, which is the referral one that we just created. Go OK. Update our demographic. Okay. And we want to go to our referral tab because now we want to update this to ready for triage if it's available for provider to triage or rejected. So when I said ready for triage, go complete. And then that will land on the provider queue, which I will quickly go ahead. So this is what the provider sees, the referral management end page. They have a save filter that they can run. If they run, they'll see this patient already in the triage queue. So they click on the patient. They review their chart, and then they place the accept order. And they can update their scheduling priority, the appointment type, reason for visit. And if the clinic decides to do this step on paper, the MOA would just update the status to accepted. And then I'll refresh. And so now the referral is accepted. And we should be able to see this in the scheduling book where the clerk books an appointment. I'm going to move on to the scheduling book. And then we'll find our bookshelf, which is VGH trauma in this case. We'll go to our appointment inquiry. We're going to go to our request list. It's called a request by queue, and then this is our queue, the name of our queue, and then we just find, and the patient is here to be booked. So what we need to complete a request is to right click, complete request. We'll go ahead, close. And then we just need to fill out these mandatory fields. Interpreter required, we'll say no. Visit modality, we'll say it's an in-person. And that's all the mandatory fields. And you can click OK. And then we'll just need to drag our patient to the appropriate time and the appropriate provider. Okay. And once you see all these red books, it means there's no conflict, and you can go ahead and click confirm. And in this stage, we want to double check, make sure the information is correct, and then we can also flip our encounter over here. So we click on the general tab. We click on set encounter, and then we find our referral encounter over here, and then we can modify that. Okay, so now we want to pre-register the patient and flip the encounter, so we can click OK. And then it'll bring us to the pre-register patient conversation. Okay, so we want to click on the encounter information tab. We want to select our encounter, which is going to be recurring for the most part. And for the insurance, let me see if it's already complete. Okay, so if I go complete, and it's telling me that I have mandatory fields that I still have to filled out, and the estimated arrival date. So we'll just say it's today, and then the time, 12. Okay. All right, now the patient is booked here. Okay. That's it for scheduling. Oh, let me just see what's in the chat. Okay. So now on the day of visit, the patient is here. So we want to check in the patient. So we right click our patient. Want to go to action. And we want to go ahead and check in our patient. Want to go okay, review the information. And now we want to register our patient fully. So we click on the register our patient. Update the demographic. Encounter information. So now we want to select a active encounter, which is recurring, because we're just converting from pre to recurring. And then we'll select a source of ID. Primary care provider verify, we'll just say yes. And then this is the part where we need to update our insurance. Accident-related injury, we'll just say no for now. Work-related, no. Okay, and then you'll say complete. And then this is when the label, the default labels will print. We'll just go okay. Okay, so now the patient is checked in, and this should reflect on the ambulatory organizer. So I'm just going to go into the clerk ambulatory organizer, which I believe is this one. ARD, okay. So you see this status, it says checked in. When I click on it, we can have several options. So checked in, it can mean the patient is checked in, but still in X-ray. If the patient comes back from X-ray, you can update the status to ready. And then it'll turn to a different color. So the nurse knows, okay, this patient is actually back from X-ray and they're ready to be seen by clinicians. So say nurse brings patient to room 1, we can do that. We'll just update the status to room. And then we can say room 1. Any questions so far? Okay. And that's pretty much it for clerks. So I'll move on to nursing documentation. So let me just open up the power chart for nursing. Yes, that's my nurse. Okay. So I'll still select the same patient here, assign a relationship. So all the medication has to be documented in the electronic MAR. I think we'll demo this next time once we figured out the order entry piece. But in terms of documenting like your wound, your dressing, thank you, Pinky. So what you can do is to go to the eye view. And there's this segment called the incision wound skin pin site. So what you want to do is to click on the grid to open up a dynamic group. And this will allow you to chart the wound. So we'll just say it's number 1 and it's on the foot. It's on the right side and it's anterior. And then we'll skip the last one. We'll just go OK. And this will open up the additional fields for you to document. And there's a lot of fields. So obviously you just need to document what is necessary. So for example, activities, we're just assessing the dressing. And some of these are diamond with a downward arrow. It's like a conditional field. So it means, for example, click on the dressing type. Click on this negative wound pressure. It'll just open up additional fields for you to document. And things like staple removal, those are available here as well. And once it's completed, you can just sign. And then there's your documentation. And for casting and splinting activities, there's this power form. You can go to the ad hoc over here. Adult ambulatory specialty clinic. We want to find our orthopedic. And there's this orthopedic device care power form. You can go ahead and chart. And all the necessary documentation should be in here. And once you're done, you can just sign the document. I'll just close for now. And for anything else, you can just do a regular narrative notes. So documentation, and click on the add. And there are some nursing narrative notes. You can just do your free tags. Or if you want a template, you can we can help you set up a auto text as well. Any question for nursing documentation?
So every time we have a patient and we're doing a task on them, we have to create a dynamic group then, like even if we're removing staples, like there's no option where we can just like check mark that it's done once the order's been put in. Like, you know how like there's task, single patient task list? Is that something that instead of having to
Well, we're
chart?
still trying to streamline the nursing task for ambulatory care because the enterprise for ambulatory nursing is not to use the single patient task list. And also
Okay.
certain tasks like wound, it doesn't fire into the task list as well. So
Okay.
we have to kind of get back to you on that piece, if that's okay.
Yeah, just because like that's having to create. I mean, I understand that we don't have to fill every single
Right.
component of the interactive UI, I know, but it's just
Yeah.
the process of creating that dynamic group each time
Yeah.
we're doing a task on a limb seems like we
Yeah.
went from like not charting
To
to
doing a
like
lot
now
of
we're
charting.
full on. Yeah.
But Selena, when you guys are taking out the sutures and the staples, aren't you making some kind of note about what you did and that, you know, the wound was good and that there was no dehissing or anything like that?
And we do not. So typically the physician would write, say, staples out, sutures out. So in say a case where there is an issue, we would bring it up to the surgeon, but it's rare that there is that I've come across that. I'm not sure if Neil has definitely more experience with that, but
Yeah, we would basically chart by exception, like if something out of the ordinary happened. But for the most part, for anything that's routine, it basically would get charted in the doctor's notes when they do their dictation. But yeah, I just want to echo the same sentiment that Selena had, is that it's this the amount of steps that we have to go through for 30 or 40 patients in a single clinic is really going to add a lot of time to our workflow that was not there previously.
Okay.
Do you know if there's, I think we've kind of asked you this before, but just because this covers like all of our surgery clinics, do you know if you had like a policy for charting by exception?
Like a DST or something?
No, it's just something we did historically.
Okay, we're obviously talking with professional practice regarding around like the ordering and things, and I think that's one of the components that have popped up is like, is there a decision support tool that we can utilize for these clinics to kind of cover everybody's professional practice while making it efficient for the clinic itself too? And I wonder if this is a component, like, would it be easier for like documentation if we had like a free text note for the with the auto text that had like the suture removal and like the staple removal, where you just had the drop down and like yes, no dehissing, yes, no, signed?
Yeah, that would be helpful. Anything that is fast and quick. Yes.
Yeah, I think we can set up a auto text for that. And then anything else you can just free text. Probably easier to then go into the iView.
Yeah.
Yeah. Okay. So currently you're saying even though nursing removes staples, it's only the provider that charts that.
Historically, that's what happened. Yes.
I see. Okay. All right. Okay, yeah, so I think a narrative note with auto text might work better for you guys. Perfect. Okay. So my last piece is just for the PT. Let me switch to my other power chart. Okay. Same patient. Thanks, Andy. Okay. So for PT, there's not really a power form or iView that mimics the flow sheet you sent us. So I've created something for you that
I was speaking to the St. Paul's therapists that go,
Yeah.
they have an upper extremity and hand clinic. They
Okay.
they use the ad hoc, what is it called here? Hold on. There's already one existing. I looked at it earlier today and I
Oh,
feel like that
okay.
would suit a lot of our needs.
Right.
Let me just find it here.
Or I kind of created an auto text that mimics your flow sheet.
Okay.
I can show that to you too.
Oh yeah, the one that they use is the orthopedic outpatient treatment record, like second from the bottom.
Oh, that one? Oh, okay. Sure, that.
So, and that's actually, I think, what their nurses use as well.
Oh, okay. Reason for assessment. Okay. Does this have everything you need?
Well, it would have weight bearing status, whether we have to do range of motion, the body part, and then they even have like below wound care and things like that. So I don't know if that would fit the needs for the nursing, but that's what they're using at St. Paul's. So I'm wondering if it does need to be a little bit more consistent. However, let's just take a look at what you've got as well, because if it's modeled similarly to this, like they say, this is very easy for them.
Okay. Okay. Yeah, we can certainly do this for sure. Or we can, it's just an auto text I created. That looks like your flow sheet with drop downs, and then we can modify this however you like. If this is what you like, you can also utilize this one.
Okay, I've got a team meeting coming up in a couple of weeks. So so if I took your auto text copy under, is it Tommy Chung? Or if I took it to just so that I can show it to everyone, because I don't have access to this unless I auto text, like copy your auto text, right?
Yeah.
But are you under Tommy Chung?
I'm actually under build. I don't know. Can we copy auto text under build? Anyone on my team knows?
Just so that I can review. I mean, obviously it looks very similar, but just to show them what it looks like, or maybe I'll just take.
Can I send you a screenshot then? That'll probably be
I'll
easier.
take a screenshot.
Yeah.
And then maybe you can send me that as well.
Yeah.
Because that is definitely what they're using for their hand clinic. But they're definitely, and they have more drop down menus, but they're a bit more descriptive so that I wouldn't have to type anything extra in here. I mean, either or is probably fine.
We can modify this to include more drop down as well. Yeah. So whatever works better for you, we can do that.
Okay. Yeah, if I can get back to you on that after talking with the team.
Perfect.
That'd be great.
Okay. And
sorry to interrupt.
Yeah, go ahead.
Sorry to interrupt. Is this what we were discussing earlier from nursing as well? Like this would be where it would be a click and then yes.
Yeah, yes.
Okay.
Yeah, we can set this up for you. Yeah. Would this work for you?
I will ask my coworkers and see what they think as well.
Okay.
I just don't think that creating a dynamic group would be something that we would want to take.
Okay.
Or
I think there's already I think it might be a smart template or something already created for it. So we might be able to send you a screenshot. I can just find that and send that to you.
Thanks, Amanda. So for more complex wound like VAC, do they have to use the iView, or can they also use narrative note? I'm not sure.
That's a good question. That might be a wound care. We've been in touch with a professional practice has been in touch with us for the wound care aspect. I'm not sure. We might be able to develop a kind of like a similar auto text to the iView section. Maybe that's not as cumbersome depending on how much you would actually realistically document in the clinic. We can explore that one, then I can bring it back during our plastic session, since I think you might be at that one too.
Yeah, we just want to make it as efficient for the clinic as possible because we know your volume is really high.
sorry, I just want to clarify. So there's absolutely no way to make it as like a single patient task list. If it was just like 2 items where it staples out and then sutures out and then done.
Do staples and sutures fire into the single patient task list?
I think
have
if we
to- I
do
have
it,
to-
I think if it's an order, it can, but then it still comes back. It sort of comes back to the professional practice aspect where that doesn't eliminate the responsibility of actually documenting what you've done and how the patient responded to it,
Oh,
which
so
is more the aspect of the iView section.
Okay.
Unless it
So-
pops up like some of them do pop up like a power form or something. If you wanted to go like a power form route that would have like those check boxes like we were looking at with Lizette's OT form.
Yeah, like the ortho service tech form. On that one, if it's in the power plan, you'll fire into the single patient task list, and then you can right click to complete, and then that will open up the power form automatically.
And the power form was what was in the documentation as a free text.
You mean the orthotech one?
Oh, that okay.
Yeah, the
Yeah, it's
one
one
that
of
has
those
many
ones.
pages. Yeah.
Okay.
Yeah, so we'll take all those into consideration. Thank you. Anything else? Okay, if not, we'll end the session. Thank you so much. And apologies for going over time again.
Thank you.
Thanks, everyone.
Thank you.
Thank you.